None of the content on this or any episode of the Kratom Science Podcast, Kratom Science Journal Club, or on any page of kratomscience.com is intended, nor should it be considered, medical claims or medical advice. This is the Kratom Science Journal Club with Dr. Jonathan Cachet, neuroscientist and expert in psychopharmacology. In each episode, we discuss an article in a peer-reviewed journal. I'm your host, Brian Gallagher, blog and social media writer for KratomScience.com, your source for all things Kratom. You want to talk about the Cannabis Museum first?
Yes, some exciting news on the Cannabis Museum down here in Athens, Ohio. So, we had talked in the past and we were sort of going back and forth with small improvements. We're renovating this building from the 1800s that was a general store to a mining company. And so, of course, things pop up. But long story short, the museum now has its occupancy permit, and we are now starting to schedule events. And there'll be a whole program of events as we get those developed. Where general public can come in and see the collection or walk through the gallery once we get that schedule in place. But we do, however, have our first art show coming up. It is an art show that features art created for the Grateful Dead and other performers. Artists include Stanley Mouse, Rick Griffin, Alex Gray, and many others. It includes many artist-signed posters and original paintings. So most of these are original paintings, real deal, with certificates of authenticity, drawn by those very famous guys. And so if you want more info on that, you could just go to @CannabisMuseum on the social channels, or find us on Facebook. Our page is called the Cannabis Museum. But feel free, if you get lost and you want to learn more, feel free to reach out to me on Twitter @JCachet. But yeah, very excited to announce that, Brian, and hope to get you and maybe even the broader crew down here sometime to check it out.
Yeah, when is that art show? When is the art show going to be?
So it will start on the 14th. I think we're going 14th, 15th, 16th. So we'll be open that weekend, and then we might open again. That's what we know for sure. But it's going to start opening more regularly moving forward. But for what we know for sure for this one now, October 14th, 15th, and 16th.
So is that just the art show, or is that the actual grand opening?
That's that. So what will be on display, do you mean? In the gallery will be the psychedelic art that will be up for sale. It's not going to be like the entire collection of the Cannabis Museum stuff.
Okay. Cool. Yeah, and I'll link to the event page and all the pages in the description.
At some point, I'm getting a exhibition, or I'm going to be the director of the exhibition that we'll probably have open for 2 to 3 or 4 weeks that people can come in and check out. But I just mentioned that because I'm going to be the curator putting together the show. It's going to be based on the stuff that I think is interesting. So maybe I'm a little bit biased, but I know for sure that one's going to be a great show. And this psychedelic art show, these are one-of-a-kind original paintings by Alex Gray or, those guys. It's just sort of amazing to even be in the same room as them.
Wow.
But yeah, exciting things to come, and the museum is open.
That's awesome. So, yeah, this paper is, the title is Kratom Alkaloid Mitragynine, Inhibition of Chemotherapy-Induced Peripheral Neuropathy in Mice is Dependent on Sex and Active Adrenergic and Opioid Receptors. That's the title. This is from Temple University's Center for Substance Abuse Research and their Department of Pharmacology. And yeah, it was one of those ones there where they seem to cover all the bases there, and it's good for 2 reasons, because I don't think we've ever talked about mitragynine as a chemotherapy pain relief drug, and I don't think there's been much on it. And another thing they do is address the differences between male and female with pain threshold and
right.
Yeah.
Yeah.
And that's a good one.
I thought it was pretty great just to even tackle, like, I guess I don't know why it sort of struck me as like, oh wow. I was sort of like, oh wow, in terms of how clearly we know that these cancer drugs cause long-term lasting like neurodegeneration, and that leads to the pain, and dealing with that pain for the rest of your life. So yeah, it's like not it's like I guess just for me uncovering that when you get this chemotherapy and it leads to nerve damage, and in the long term, even if the cancer's gone, that long-term nerve damage can persist, causing permanent uncomfortableness and pain. And so how do doctors treat that, I think, is what we're getting at in this, right? If I read it right, is that right, Brian?
Yeah. And so this particular one is chemotherapy-induced peripheral neuropathy. So this is like neuropathic pain. So I talked to a lot of people on here that have had, I mean, this would be closer, like fibromyalgia has like a neuropathic element. And then there's, people who use Kratom because they were injured in the past, or they've worked in physical labor their whole lives and it helps with that. But this is like, this is another paper showing that the mitragynine helps with chemotherapy-induced peripheral neuropathy, and I looked up a definition for that, and this is from the JAMA network, and I'll have the link to that, but it says peripheral neuropathy refers to symptoms arising from damage to peripheral nerves. These nerves carry sensation, control movements of the arms and legs, and control of the bladder and bowel. Chemotherapy and other drugs used to treat cancer can cause peripheral neuropathy. The particular chemotherapy drug they're using in this is oxaliplatin. I have the pronunciation.
Oxaliplatin.
Did you hear that? Oxaliplatin.
Yeah.
Yeah, oxaliplatin. That's exactly the word I was looking up how to pronounce too. Oxaliplatin.
Yeah.
Or you call it the O word, or the big O. Maybe that's tough. Oxaliplatin.
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 Sally.
Oxaliplatin. Okay.
Yeah, but yeah, so apparently, I mean, this causes this so often that you can just give it to mice to induce that kind of condition, which is interesting. And then the condition is, allodonia. Allodonia, yeah. And allodonia is defined as pain due to a stimulus that does not normally provoke pain. An example would be a light feather touch that should only produce a sensation, but it causes pain. They had equal groups of male and female mice. They gave them this oxaliplatin, and that induced this condition of pain.
Right, the animal model of the pain. Right, yeah.
Yeah, and I'm just reading, I'll just quote under the results. It says oxaliplatin produced mechanical hypersensitivity of approximately equal severity in male and female mice. So they're starting with like a pretty equal baseline in the sexes. Along with mitragynine, they're testing kind of the receptor pathways. So they're going to use naltrexone, which is the opioid antagonist. They'll use prazosin. That's an alpha-1 adrenergic antagonist. The yohimbine, alpha-2 adrenergic antagonist, and propanol. Propanol is the beta blocker, or it's also the beta adrenergic antagonist. So these are all drugs that are used for other conditions, but they're basically, I guess they're using them in mice to test pathways that mitragynine takes in its analgesic effects.
So for certain, yeah. Propanol, also known as the Michael Jackson drug. That's what he was getting injected with the day that he died. He was sort of addicted to that. Yeah.
And that slows down your heart rate, because I looked up a little bit for that, and it's usually prescribed for high blood pressure. Yeah. Oh, he took
for
propanol.
Sure.
Okay. I thought that was... Prince was fentanyl. Prince was fentanyl.
Yeah, or poly at this point. But I thought you broke it down very, well. Like in order to understand, like to tease apart some of the mechanisms behind it, they were using all of these known and often used, like the naloxone or naloxone in the studies to sort of say, okay, well, is it scenario A or scenario B? And by using those different blockers that would presumably prevent the effects from the mitragynine from reaching the receptors, they can tell what is like necessary for an improvement and what isn't necessary for improvement. So, yeah, I think you characterized that great. Can I just let me say just philosophically, and I don't know, maybe it's the mood that I woke up in today or what, but and I haven't been in a neuro class in a while. But to me, like, it's just so wild to me that you can get exposed to a drug, and you can even be exposed to a drug in a medical setting, like these chemotherapy agents, and it is very clearly causing nerve damage, and you're going to end up with like a neuropathy your entire life. But the benefits outweigh the risks in most cases. Most people would rather want to get rid of the cancer, but ultimately you have some form of neurodegradation, right?
Yeah.
And so that degradation only surfaces and like its symptoms are mostly internal and pain related. On the flip side of that, you could take another drug, and there's many other different ones, but that also lead to like prolonged exposure to an amphetamine or a dopaminergic will cause neuropathy in different dopaminergic neurons, in central and also periphery, but that leads to movement disorders, and that the problem or the risky side effects of the cancer drugs that lead to pain. Why aren't they shaking also if it's a nervous system degenerative order? It's a rather rudimentary idea that I'm exploring or like skirting around here. Sometimes I get stuck in the awe of like a lot of people, and I think a lot of people get stuck in the awe of saying like one machine or one system is used to do X or used to do Y. But then when you break that machine down, depending on how it broke down, you can have vastly different outcomes, whether that be like uncontrollable movements or seizuring, all the way down to things that people can't even see, but you are subjectively experiencing. And it's kind of wild to me.
I didn't really look at what exactly the oxaliplatin does in the first place. I mean, it's chemotherapy, so I guess that it actually kills cancer cells, right?
Do we know that it causes neuropathy pain and like pain? So now we're just giving it to animals at the higher doses than normal in order to study the pain and where it comes from. It just seems kind of wild. So it looks like it is a type of molecule that when injected into the body, and I think it was discovered with rectal cancer, colon cancer, colorectal cancer, it interacts with the DNA of your blood cells in that area. And, of course, cancer cells, one of their, main sort of ways to survive is to trick angiogenesis and get more blood brought to them than the other surrounding tissue. But what it sounds like is that it just basically is attracted to these cancerous cells and almost fight them. According to in vivo studies, oxaliplatin fights carcinoma of the colon through non-targeted cytotoxic effects. Like other platinum compounds, it is cytotoxicity is thought to result from an inhibition of DNA synthesis in the cells. So in particular, it forms both inner and intra links cross cells in the DNA, which prevent the DNA from replicating. So yeah, I guess it's the plasma helps the doctor sort of target and get it, or the platinum, they're platinum tagged, help them get it to where they need to get it to sort of concentrate in the area around where your tumor is. And then it sounds like it's just pretty non-specific cell death in the general area by messing up the transcription of the DNA completely.
Okay. So that's probably why it would like cause all those side effects, I guess, since it's non-specific.
Yeah, and so I guess it would be because it's non-specific, but like in Parkinson's, it's very specific. We know what neurons die, and that leads to Parkinson's, and it just wild to me. It's the same system, two different outcomes. But yeah, I think the non-specific effects of the chemo, and I think bringing your immune system down so you can, fight off, what is directly in front of you. Yep.
So you get cancer, you get cancer, they'll give you this drug that gives you all kinds of side effects, and that's where I get to this part. I'm just going to read from the introduction a little bit, but it said drug classes implemented to treat neuropathic pain include antidepressants, anticonvulsants, and opioids. Compounds such as mu-opioid receptor agonists are not optimal for chronic use due to the limited therapeutic benefit and increased risk of harm, despite being used by up to 97% of CIPN patients. Currently available treatments for chronic neuropathic pain are effective in less than 50% of patients and are often accompanied by adverse effects during prolonged use. And then I read kind of from the study a little bit that they cited for this, because I'm interested in, like, I thought, a lot of these opioids would help most people, but I guess by risk of harm they probably mean addiction or dependency.
It's like a political lack of favoring.
From this study, it was the Finnerup 2015. I'll read from that a little bit. Strong opioids are now recommended as third line, contrasting with several prior recommendations in which they are generally considered as first or second line. This mainly stems from the consideration of potential risk of abuse with high doses and concerns about recent increase in opioid-associated overdose mortality and misuse. So that was from 2015, this study that they cited, and that's pretty interesting because, like, it wasn't until 2016 that the CDC put out those guidelines for opioid prescribing, which they plummeted in prescribing, but then overdose deaths from, like, street fentanyl started skyrocketing. So
there was one part where you were discussing what patients do use for, basically the point I'm trying to make though is it was like 96% of the cancer patients are using opiates. I would argue that's because they work, and that's different from the concern of long-term addiction or dependency. It's not necessarily that these don't work for them or they're subpar. They work in controlling the pain. In fact, that's why the large majority of people are on them in this scenario.
And then the other ones were antidepressants and anticonvulsants. I don't know exactly how they help with actual pain, especially like neuropathic pain. I guess anticonvulsants, the condition we were talking about before, allodynia, might help with that since it's, it affects the movements. And the other thing they talk about here is differences in sex, and I'll just read from that. This is the introduction still. In general, CDC data suggests that the prevalence of both chronic pain and high-impact chronic pain is greater among U.S. adult females compared to males. Several studies have reported greater prevalence of numerous forms of neuropathic pain in females, but it says CIPN from oxaliplatin occurs in comparable rates among males and females. That's why they chose it for baseline. They also say, and I don't think I highlighted it, but they also say about the whole pain thing and the abuse. This is basically why they're testing mitragynine, because it has lower abuse potential than the opiates. They usually say that in a lot. I mean, that's the reason they're doing a lot of these, because they're looking for a less addictive, so to speak, pain treatment.
Yeah, and this paper's pursuing it mechanistically, right? Where we have all of those, and they're being mindful of potential sex hormonal differences and how that affects the outcomes. So I think we set the stage here for a pretty good experiment.
Yeah, and it says they do mitragynine at 1, 5, or 10 milligrams per kilogram, which I didn't do the human equivalent dose, but that seems pretty high. And then it said, okay, so the differences for the male and female. Females started to see the analgesic effects at 10 milligrams per kilogram at the high dose. I think males started at 5. So that kind of backs up the hypothesis presented that, females have a lower pain threshold. And it says mechanical threshold. The results I'm looking at I'm going to look at like the charts, the figures. Mechanical hypersensitivity. Yeah. So what is that exactly? Mechanical threshold, I mean. They show mechanical
I think they're using a hot plate. Baseline mechanical sensitivity. And mechanical sensitivity would be anything that you, like, are touching. So if you have your hand on the top hot plate, and how quickly you move it off once it reaches a certain temperature, what temperature that is when you pull your hand off, that would be a measure of your sensitivity to that. And so different animals have different sensitivities. It could be like a shock. It could be keeping your hand on ice, but it's something that is like you could be getting pinched. It's something that is like physically happening to you that you would naturally pull away once it started reading a certain threshold. And then so when you change from that, you either can experience more pain or less pain. That's the idea.
Yeah. You know what? I think they didn't have to do the hot plate because the oxaliplatin induced the hypersensitivity to pain, the allodonia, where...
Oh, yeah. I think you're right. Because they were already exposed to the drug, they're already experiencing neuropathic pain to a certain extent. And their baseline would be lower.
Yeah. Mechanical allodynia was assessed using Von Frey monofilaments of varying forces applied to the plantar surface of the right hind paw. So they were poking their paws.
I think that's a scientific term for them, but I would describe them as like little feather ticklers with known diameters, and like the smaller they get, it'd be like you just have a very nice set of these metal things that go from like 0.01 millimeter up to like a millimeter. And depending on, the type of data you're collecting, but yeah, depending on the size of the poker, that gives you an indication of the sensitivity there. Good call, Brian.
Yeah. yeah. So they didn't need the hot plate. Okay.
Figure 1 is looking at the differences between the control and those that were exposed to the oxaliplatin,
oxaliplatin.
Cancer chemo. Yeah. What is it again?
Oxaliplatin.
Oxaliplatin.
Yep.
So I think this is showing that the baseline versus oxaliplatin, the oxaliplatin animals by day 2 and definitely by day 4 and 5 have a much lower sensitivity than the controls that were not exposed to that chemo drug.
Figure 2, it just shows oxaliplatin with the vehicle, and then with 1, 5, and 10 mitragynine. Males had a higher mechanical threshold across the board than females, and females it looked like it started to work most effective for both at 10 milligrams per kilogram of mitragynine, which makes common sense.
I see what you're saying. So maybe you can maybe suggest that in females a lower dose females potentially could use a lower dose to get the same amount of release.
Well, I think the females actually need more for it to be effective because they have a lower. Let me read the note that I pulled out. Mitragynine prevented the development of oxaliplatin-induced mechanical hypersensitivity in both male and female mice. In males, mitragynine significantly inhibited oxaliplatin-induced hypersensitivity at doses of 5 and 10 milligrams per kilogram. In females, mitragynine produced significant anti-allodonic effects only at the high dose of 10 milligrams per kilogram. However, we found that 10 milligrams per kilogram mitragynine produced significantly higher mechanical threshold values in males compared to females, suggested of sex differences in the therapeutic efficacy of mitragynine.
So the only clinically significant, statistically significant one was the difference between the drug plus vehicle and then the drug plus 10. So the first bar and the far bar, those were the only significantly different ones. Overall. Is that right? Is that what you just said?
In males, it was 5. It started at 5, and this is figure 2. And then in females, it was only at 10 in the female mice.
Oh, gotcha. Right.
So they said 5 and 10 in males and 10 in females. They don't really have a line for where it's statistically significant. I guess it would be 0.6 or higher.
It is. Yeah, it's a little tough one to figure out. But I guess the walk away on this one is that both male and female mice, like we can reduce their neuropathic pain through at least 10 milligrams per kilogram body weight of mitragynine. Thus far. That's what we learned here. Yeah. Okay.
What is figure 3 just kind of just zooming in on the male and female differences? Yeah. Figure 3 is just kind of what we talked about. They're just kind of zooming in on that 10 milligrams per kilogram. Now, figure 4...
Yeah, they're just zooming in on the ones that are relevant. Hold on real quick, because this is just the relevant ones here. So it is that the male first dose vehicle compared to highest dose, significantly different. Within female, lowest dose vehicle versus highest dose mitragynine, significantly different from each other. And there's a difference between the male and the female in terms of their mechanical threshold after mitragynine.
It seems like a big difference, but like twice as much.
Right.
Whereas when they just get the vehicle with the oxaliplatin, they're about the same. Males are slightly higher, but once the mitragynine gets in, males have like it affects males better because they have a much higher threshold for the pain, and so it's I guess it would suggest that the female mice need more mitragynine to get to that higher threshold level.
Or they would need even more mitragynine than this in order to sustain pain up to that level.
Yeah. The next part is all the different antagonists that they are given. And it still shows like pretty significant differences with males and females for the mitragynine, but not so much for the naloxone plus mitragynine. It's about the same. Not naloxone, naltrexone. Yeah. That's what I meant to say, naltrexone. In the mechanical threshold, naltrexone lowers the effects. And I could just read from it just to explain it a little better. So, naltrexone pretreatment significantly blocked the anti-allodynic effect of mitragynine alone across all 3 doses in males, indicating a mu-opioid component of mitragynine. We kind of already know about that. But interestingly, though, it says no dose of naltrexone test significantly blocked that of mitragynine alone in females, suggesting differences in the opioid components of mitragynine between sexes. Prazosin was the only test that inhibited mitragynine's therapeutic effect in both sexes. This suggests a central role of alpha-1 adrenergic receptor activation in mitragynine pharmacology.
Interesting, yeah.
Yohimbine is the alpha-2 adrenergic, and it significantly blocked mitragynine's effects to males only, and propanol was the only antagonist tested in which its pretreatment did not result in significant inhibition of mitragynine's anti-allodynic, which means in this case anti-pain, but they're being specific to the type of pain, in either sex, suggesting that beta-adrenergic receptors likely did not contribute to the development and maintenance of CIPN. And it also says the dual mu-opioid and alpha-adrenergic components of mitragynine raises questions of whether these receptor systems are activated to achieve therapeutic efficacy through independent mechanisms or perhaps acting in a synergistic manner through a common downstream pathway. But I'm not exactly sure what that means, but I want to get back to that. But I was going to bring up Abhishek Sharma, the scientist at University of Florida, was talking about how And we've had another paper that showed the adrenergic effects of mitragynine, but he was talking about how, and I'm going to play the clip here, and I hope this works, but he was talking about how mitragynine is a combination of drugs used to treat opioid dependence, because it does activate the adrenergic receptors, and I might actually cut it down. Yeah, and this is from episode 45, I think. Yeah, of the podcast. Here we go.
If you think about like what people give for what we need for any opioid dependence or opioid withdrawal syndrome, like what kind of treatment do we need? So what is in marketplace is either they will give a weak opioid agonist, so it will occupy the receptor but will not activate that particular pathway which is responsible for the problem. The second treatment is you give alpha-2, you will go through alpha-2 agonist properties, like you do clonidine, you do lofexidine. But when you look at the mitragynine molecule and you look at the mitragynine receptor binding data, so first thing, mitragynine is a partial opioid agonist. You give any amount of mitragynine, the maximum effect you can achieve is 40% of any full opioid agonist like Damgo or morphine. So you will never reach at that particular high thing. Then it shows activity through alpha-2 receptor. The same activity you get it through through clonidine and lofexidine. And then it acts through serotonin receptor and as well as dopamine. So the mitragynine itself is a combination of 4 drugs, given the 4 different receptor binding, receptor occupancy thing, receptor binding thing, which you need to treat opioid withdrawal. And that is the advantage this molecule have. It's like you mixed 4 drugs in a treatment therapy to treat the opioid dependence, and you can get the same thing with one mitragynine molecule.
Yeah, so that's it. He was talking about how mitragynine does the work of those 4 drugs that are given for opioid addiction treatment.
Yeah, hits all 4 of those targets. That's interesting stuff, man.
Yeah, and so it's kind of cool here because it's saying, well, maybe the adrenergic component of it is also part of the pathway that treats the pain. It's not just mu opioid, because I think like 7-hydroxy is just the mu opioid receptor. It's a partial agonist, but it's like highly selective of that one receptor, whereas this is shown in this that mitragynine acts on adrenergic as well. So it's like kind of like unique in that way compared to other opioids that they're using for this kind of pain treatment.
Yeah, and also, I mean, is opening up our understanding of what pain is and what causes it. I think that gets back to sort of the stuff I was talking about, Parkinson's versus like a lifelong neuropathy, right? It's the same system, but there are many things that can go wrong with it. And like most times we tease out these like very tight, complex interactions and connections that are always ongoing and always unchanging. Like, well, when one part of them goes wrong, and then we can get in there and like say, oh yeah, it was this part that went wrong. And now we know that that's sort of the primary etiology of a certain disease set. So, I think we talk a lot about the different receptor subtypes and the plants, but as it always is, it's complex plant. It's with a complex profile going into a complex brain. But we keep at it, and then maybe we'll learn something at the end of the day.
Yeah, and just the mitragynine alone and in itself is complex. And it says,
right
in this part, I read it before, but I'm trying to figure out exactly what this means, and maybe you can shine light on it. But it says the dual mu opioid and alpha adrenergic components of mitragynine raises the questions of whether these receptor systems are activated to achieve efficacy through independent mechanisms, or perhaps acting in a synergistic manner through a common downstream pathway. So what do they mean by independent mechanisms and common downstream pathway? I'm not exactly sure.
So with just getting that sentence for face value alone, I don't know exactly what they're talking about, but a good analogy would be essentially like through independent interactions or independent mechanisms. So an independent mechanism would be like, you want to open 3 windows of your house, and you go and open one window, and then you got stuff coming in through that window. You open a second window, and it comes in through that window. Let's say it's raining on the side of the first house, so you get rain coming through that window, and then sunny day on the other side. Versus a synergistic action is essentially like, sliding those 2 windows together or opening a double bay door. It's that the 2 separate things that can function independently and allow things to pass through them come together now. And then most times they're just like, it's 2 windows that are not joined. They're just not separated by a wall anymore. The dimerization. So, receptors that function on their own independently and have specific ligands, or they end up like bumping around in the neuronal wall, the sort of stew up there, and form these dimers or tridimer. There's more than just 2 with other receptors, and that can have changes downstream in terms of what proteins are released and how it may affect like DNA translation or transcription. And it's like with beta-arrestin in the Kratom conversation. So if it doesn't recruit and bind beta-arrestin,
okay, yeah.
That's...
All right, I kind of understand that a little better now. And then the next one that says, interestingly, evidence suggests opioid adrenergic synergistic interactions are limited to the spinal cord. Overall, this distribution pattern suggests mitragynine may achieve therapeutic efficacy through modulating active opioid and adrenergic receptors that are in series with one another within spinal pathways.
It is a central loci, and maybe it is for the adrenergic opiate synergistic interactions. Like it's a different type of pain, something that like It may be a different neurotransmitter for heat versus for cold or something like that.
Yeah.
Some pure speculation on my end.
Yeah, and they just kind of mention that in the discussion, so this paper doesn't have a very wide-ranging explanation of how that works. But I think one of the older papers we did mentioned that, but I don't think specifically that that is in the spinal cord. And the other interesting thing is they mentioned a study that reported higher concentrations of 7-hydroxymitragynine were obtained in male mice compared to females, just from metabolizing mitragynine, which is another interesting sex difference. And it did mention that they haven't done a lot of gender differences in mitragynine anyway, which it seems like with these pretty stark contrasts and the way in the threshold and everything, that they should probably do that every time they study at least a pain response.
Amen. Yeah, for sure. Your grandma gets cancer after reading this, and she doesn't want to take any painkillers, and she's not even taking. Maybe she'll take a Tylenol if it gets real bad. But are you making her a tea and just telling her to try it?
Well, both my grandmas are dead, so that's ship has sailed. Yeah. No, I mean, I would for like my sister got cancer and when she passed away from it, but I just remember all these like complications on top of the chemotherapy on top of it. Whereas my mom got it and she responded pretty well to chemo. She had like general and she never had to go in for radiation or anything. She just had to take the chemo drugs, and a lot of it was just oral drugs she took at home. But she'd be like nauseated for a week. But she my mom. I wouldn't give her kratom because it's she's prone to seizures. And I know people get like the eye wobbles and stuff, so I'd be kind of worried about giving her kratom.
Yeah,
I probably would with my dad.
I would say after this, I'm sort of neutral at this point. Like I didn't know anything beforehand. I think it's sort of like hey, it's worth a shot. It's not going to do any harm type situation. Of course, you got to check with your doctor on all of that, especially during cancer treatment. But I guess I was on the fence, and now I'm leaning towards, it'll be fine. And if it works and they enjoy it, that's great. If there gets them in the right mindset. But that's really not what the authors of this paper are saying. That's just our reading the paper once or twice and then relaying it to the public. And I wanted to catch him off guard and see if he was a pro or con. So sorry about that, Brian.
Yeah. No. I know. I went into like a way too deep, longer discussion. Yeah, and that other thing. So this company is a Vancouver-based company. They filed a patent for a deuterated form, and I'm probably not pronouncing that right, but I'll just say it like that. Deuterated form.
No, you're right.
Okay.
Yeah.
Of 7-hydroxymitragynine and they're calling it D7H. The company, they're called Nirvana Life Sciences, intends to pursue D7H as a pain-relieving drug. I just published a blog post about this, so I'm reading from it, citing 7-HMG's partial opioid agonism and the deuteration process that they say makes the drug last longer. They said that it has a longer half-life because of that process. And so the thing I was worried about is, okay, and so there was another company that actually did this to mitragynine. They have a deuterated mitragynine, and that's like Cures Inc., and they call it KUR 101, and they're in clinical trials with that now. It's a deuterated mitragynine, and I emailed Christopher McCurdy about this, and he replied that he said there's been no science in the scientific or patent literature, so we really don't know exactly, what it's going. But he said 7-OH is known not to be necessary for affinity, which I was asking him about, it's not necessary for the pain-relieving effects of mitragynine. He said it's a shape issue that is imparted to the overall structure that makes 7-0 fit in opioid receptors with great affinity and selectivity. Replacing the OH, the hydroxy, with a deuterium would afford the same shape change and allow for patent protection and possible better metabolic stability, but there's no data to base that statement on that he's aware of. So he's like, yeah, that's interesting, but we'll have to see if the data comes out. But I'm just worried because, he even told me, if you take 7-hydroxy out of the mix, he calls it like a symphony orchestra, and if you turn 7-hydroxy up on full blast, he said it's comparable to full opioid agonists like morphine and fentanyl. So it's kind of like one of those things where, if this company's going to have to be really careful about, marketing this thing, because if there's a mitragynine, I guess it's semi-synthetic, because they're taking they're just messing with the molecules so they can patent it, basically.
Right.
So,
and is there a risk of taking the heavier hydrogen molecules with the heavier hydrogen, like out of a clinical setting?
Yeah, I would think so, because I think it's probably just more habit forming, and there's been studies out that says it shows abuse potential, like some rat studies. The rats will
are you talking about
self-administer.
OH, or are you talking about just deuterated? Oh, okay. So I was just talking about the denaturated in general, like just tagged molecules. Like I don't really.
Yeah, there hasn't been any. Time. Yeah, for as far as Mitragynine and 7-hydroxy, those ones that they came up with, I don't think there's been anything published yet. It's just the companies came up with them, applied for a patent, and the one company is doing a clinical trial. It's supposed to be out in October, so if there is some kind of study out, then maybe we could look at it. But it's I found it's on clinicaltrials.gov that they are actually doing clinical trials for this Cure 101, which is the deuterated mitragynine.
Yeah, unfortunately, the skeptic in me thinks that the deuterated is more about getting in and having a patentable medication versus it is like you're making it better or worse than mitragynine for patients. But
yeah,
you got to have money to push those clinical trials through. So I'm not going to knock anybody for doing it, and not going to knock anybody for wanting to recruit that investment. I'd have to look into it more, but it's very cool. And I guess, when we started doing this maybe a year ago, I don't think I would have said that we would have, I would have guessed back then that you and me would be spending more times on picket lines, protesting certain things than sort of seeing a continual growth of more and good science and a community grow behind it, and like advocacy increasing. It's good stuff.
It's interesting, and I did email. I found the guy, but I did email the one of the founders of the company about this, and I asked if he's worried that it would be more habit forming, since there's been studies on greater abuse potential in 7-hydroxy. Did he respond? Not yet. I only emailed him this morning, but if he does, I'll include it in there, and I'll talk about it next time. Thank you, Dr. John Cachet. Check out the Cannabis Museum on Facebook. The event info is on Facebook, and it's in Athens, Ohio. It's October 14th, 15th, and 16th. The music is Captain Big Wheel. The song is called Moon Runner. Check out Jonathan Cachet at @JCachet. Please like, subscribe, share, rate, review, comment. Kratom Science Journal Club is produced by me, Brian Gallagher, for KratomScience.com. Take care.